Think of estrogen like a bodyguard for your arteries. In menopause, estrogen levels start dropping. Your bodyguard is not doing their job. The Women's Health Initiative study. This was a landmark study and basically said HRT increases the breast cancer risk. Millions of women stopped taking hormones overnight. And what happened? Heart disease in postmenopausal women actually went up and not down. Breast cancer risk went up slightly with HRT, but without HRT, women suffered more with heart disease, bone loss, cognitive decline, quality of life issues like severe heart flashes and sleep deprivation. So the question isn't, should I take HRT or not? It is what my individual risk profile looks like and how do I make a decision that accounts for my overall health picture.
One in 3 women over 50 is taking hormone replacement therapy, but nearly all of them are confused about one question. Will it save my heart or damage my breast? So today we're unpacking the 7 billion hormone therapy replacement industry with someone who lives in the exact place where those two questions collide. Welcome to Infinite Health and welcome Dr. Maran. And this is the episode every woman approaching menopause needs to hear. So super important episode. It's nice to see you as always. How are you doing today, by the way?
I'm doing great, Layla. How are you doing?
Good, good. We were chatting a little before we recorded about how important this topic really, really is and how many women it really affects. So I'm excited to get into it. And menopause is something we've talked about briefly in other episodes. And we talked about perimenopause in other episodes as well, which is something that I think people are starting to talk about a lot more than before. So excited to hop into this episode with you.
Thank you. This is truly a very personal episode for me. Even professionally speaking, I've seen so many patients come to me asking a binary question. Do I take hormone replacement or do I not take? It's like a yes or no questions. And sometimes I also see a lot of breast cancer survivors where the chemotherapy medication, which saved them from cancer, gave them heart disease and also gave them early menopause. And how do we navigate it in the presence of heart disease, breast cancer, HRT? What do you do then? So, there is no yes or no answer to it, but there is a lot of no answers. So, this is going to be a very interesting conversation.
Absolutely. And yeah, I'm so interested to hear how you feel about it because you're basically, like you said, you treat survivors as well and see how certain things affect them. And just interesting to really hear your perspective on it. So you're a cardiologist who specializes in treating coronary artery disease in women. And that's a group that's historically been overlooked by the medical system, I would say. So what's interesting about you is that you also treat breast cancer survivors, as you said. So you're literally kind of standing at this intersection of these two major health issues that women are really terrified about. So I know you mentioned this is a personal episode for you as well, but why did you become so focused on this particular population?
You kind of actually answered the question itself, Layla. I kind of focused on this population because this is an ignored group of patients. Okay. More than 50% of the world's population are women. And most of them, or one half of them, are probably menopausal, perimenopausal, postmenopausal. And this entire group of patients get completely ignored. Very less research is done about them. Heart disease in women, even though it kills more women than all cancers put together, does not get the recognition it deserves. Women get underdiagnosed, undertreated, and completely ignored. So this subject is very, very personal to me. I'm very passionate about it. My own best friend's mother went to the emergency room with chest pain and they discharged her home without doing any basic tests, and she died the next day. So, heart disease in women is completely ignored, and menopause in women, there's a lot of noise about it, but no one knows what to do about it as well. There's no clear cut. There are a lot of OBGYNs who are afraid of hormone replacement therapy in menopausal patients. So, I feel like I, who see both ends of the spectrum, I'm very uniquely qualified to talk about hormone replacement therapy and what it does to the heart and vice versa.
Absolutely. Yeah. I'm so sorry to hear about your friend's mom because I know that that's really difficult, especially being a provider and thinking about how it could have potentially been avoided, and especially that she went to be seen and they likely didn't do the right things by her. So that's definitely something that's hard. And I think that I mentioned earlier, this is something that women are kind of terrified by, right? Like everyone's kind of terrified of these things. Menopause is hard and dreaded. And we talked about this in previous episodes too, about how to navigate it without the fear. So, is this really about moving beyond the fear?
Absolutely. Fear sells, right? But evidence based medicine, that's very hard to market. So today, I think we should talk about the actual evidence and see where the conversation leads us.
Absolutely. And let's kind of start with something a lot of women don't realize. So, and I didn't realize this. And it's scary. So, your risk of heart disease actually increases dramatically after menopause. So, is that because of the hormones or is there something else or some kind of coincidence?
It's definitely not coincidence, okay? Premenopause, you have estrogen, and it's actually a great protector. Think of estrogen like a bodyguard for your arteries. It helps your blood vessels stay flexible and pliable. They can dilate, they can contract, they are responsive, okay? And estrogen also helps regulate inflammation, keep your cholesterol profile more favorable, and even helps your heart muscle work more efficiently. So, in menopause and perimenopause and menopause, estrogen levels start dropping. And basically, your bodyguard is not doing their job. And all of a sudden, the protective effect starts to disappear. Blood vessels become stiffer, inflammation increases, your cholesterol ratio gets worse, and your heart attack risk accelerates. Here's a striking statistic for you. A woman's risk of coronary artery disease before menopause is about 1 in 200. After menopause, it's about 1 in 50. That's a fourfold increase.
That's a drastic statistic. So, when estrogen drops at menopause, what exactly happens?
Estrogen drops at menopause. And as I said before, your blood vessels become stiffer. Your fat profile ratio kind of completely changes. Your body composition changes. Women start depositing more fat around their belly. And that fat is not an inactive, inert fat. Rather, it's a more inflammatory and very hormonally active fat. And it produces a lot of inflammatory cytokines which overall just triggers whole body inflammation. Women develops features of this of estrogen deficiency from head to toe. You get more brain fog. You're physically more tired. You have more aches and pains. What you are able to do very efficiently becomes overwhelming now.
That's difficult because I feel like that's so common even before menopause. And I think that that's why HRT sounds so promising, right? Because you're replacing what you lost almost. Is that fair to say? Is that right?
On paper, yes, but here's where it gets a little bit more complicated. And this is where we need to separate the hype from what the evidence actually shows. Okay. All this, started at the early 2000 study, the Women's Health Initiative study. Okay. This was a landmark study and basically said HRT increases the breast cancer risk. Okay. Millions of women stopped taking hormones overnight. And you know what happened? Heart disease in postmenopausal women actually went up and not down. So when heart disease started going up, they started wondering what is going on. Okay. The women's health is truly a complex system, and we have to be very careful about how we manage it. And that's why you need real doctors taking care of it. What the data showed in the Women's Health Initiative is correct. Yes, breast cancer risk went up slightly with HRT. We thought women suffered more with heart disease, bone loss, cognitive decline, and quality of life issues like severe heart flashes and sleep deprivation. So the question isn't, should I take HRT or not? It is what my individual risk profile looks like, and how do I make a decision that accounts for my overall health picture?
And I think that that's where a lot of women get lost because there's the standard HRT, bioidentical HRT, compounded HRT, And online, people are talking about them like they're completely different drugs. So is that true? Are they different drugs? Are they the same?
Okay. Another great question. The question is not as different as the marketing makes them sound. So let's break this down in a way that kind of makes sense. First, there is conventional HRT. That is synthetic HRT. These drugs are FDA approved. The most common ones are the conjugated estrogens, and they come from pregnant mare's urine or synthetic estrogens made in the lab. And then there is progesterone, which is the synthetic form of progesterone. So that's what is the main form of HRT. It is either grown in the labs or made in the labs or taken from animal sources. The marketing world has gotten so good in saying this is synthetic and therefore it's unnatural and therefore it's bad. Now here I am with bioidentical hormones, which are natural and therefore they are good. Here's the truth. Bioidentical hormones are still made in a lab. They are just made to be chemically identical to the hormones made in your own body. So estradiol is estradiol, whether it comes from a pharmacy synthesized in a lab or whether you get it from a compounding pharmacy. The molecule is the same and your body does not know the difference. Okay, but they sell it as bioidentical is safer, and they've built this whole wellness industry narrative that bioidentical is safer. The evidence does not support that bioidentical hormones is inherently safer. What does matter is the dose, the route of administration, and what you are combining it with. So let me be very, very clear. Bioidentical versus synthetic is like Coca-Cola Classic versus Coca-Cola Zero. They both sound very different, but the health impact depends on how much you drink it and not in what bottle it came from.
Interesting. And then you mentioned pregnant mare urine. So what exactly is that? Is that sounds like actually something your grandmother probably took?
So, I don't think we should even need to focus on whether it comes from a mere source or a lab source. It truly does not matter. What matters is the dose of the medication. Lower doses are generally safer than higher doses. And number two, the route. And that's truly very, very crucial. So let me explain a little bit. Okay. When you take a pill, orally, the estrogen goes through your liver first. Your liver processes the drug, and in doing so, it increases the inflammatory markers and it can affect the blood clotting factors. That's actually one reason why oral HRT is associated with a slightly higher clot risk in some studies and slightly higher stroke risk in certain population. But when you use it as a patch, a transdermal patch, cream or gel, it bypasses the liver. They get directly absorbed into the bloodstream. And the cardiovascular and cancer risks appear to be lower with transdermal delivery than with the oral pills. And that's based on multiple European and international data. And also, from a cardiovascular perspective, the evidence suggests that transdermal delivery is way better than the oral delivery of estrogen. Now, there's this third component, progestin. If you have a uterus, you need progesterone or progestin to balance the estrogen and protect against endometrial cancer. And here's where the synthetic progestin versus the microionized progesterone might actually matter. The synthetic progestins, that is the medroxyprogesterone acetate, they can sometimes increase inflammation and worsen metabolic markers. A microionized progesterone, which is the bioidentical format, might be gentler, but the data is mixed. So, what is clear from the French E3N cohort study, which is a massive European database, is that women using estrogen with microionized progesterone had lower breast cancer risk than women on synthetic progesterones. That's about it. So let me consolidate. When it comes to HRT safety, dose, route, and progesterone type matters. Lower dose patch instead of pills, microionized progesterone instead of synthetic progesterone is where the evidence based science lies.
So this is the big one. Every woman I know who's considering HRT or even thinking about it really asks, is it going to give me breast cancer? And how do you answer that question?
Okay, let's get very specific about what science actually says here. Your baseline risk, that is a risk that a 50-year-old woman will get breast cancer in her lifetime, is about 12%. That's 1 in 8. Okay. But when you take HRT for 5 years, studies show that risk increases to about 13%. So you go from 12% to 13%. Okay. So you go from 1 in 8 to roughly 1 in 7 or 1 in 6. This is a real increase, but it is not doubling your risk. It's about a 20 to 30% relative increase in absolute time. Now, I'm going to go ahead and pretend I know your next question, which is when you stop HRT, does that risk go back down? Okay. That is a very important point to discuss. Within a few years of stopping HRT, the breast cancer risk goes back down to baseline, which suggests that HRT isn't causing cancer. It's potentially promoting growth of cancer that has already been there but not yet detectable. Now, here is the nuance, and I think this nuance is extremely critical. That risk is not the same for everyone. It depends on several factors. First, duration. The longer you take HRT, the higher the risk is. 5 years of HRT, modest risk. 15 years, much higher risk. That's why we talk about using HRT for the shortest time necessary to manage symptoms, usually 5 years or even less. Second, type of HRT. This is where it gets super interesting. Estrogen alone, used in women who've had a hysterectomy, does not significantly increase breast cancer risk. But the combination of estrogen plus progestin, that carries the risk. Why? Progestin promotes the proliferation in the breast tissue. And if there's estrogen too, that cell growth can potentially develop a cancer. But again, it's the synthetic progestin that show the highest risk. Microionized progesterone shows a lower risk.
So then if I'm a woman without a uterus, HRT is pretty safe from a cancer perspective, you would say?
Much safer. If you are a woman with a uterus, I can significantly reduce the risk by using microionized progesterone instead of synthetic, a lower dose, and a transdermal delivery of estrogen instead of a pill. That doesn't eliminate the risk, but it meaningfully reduces it.
And then this is where the breast cancer survivor question comes in, right? Because if you've already had breast cancer, is HRT off the table?
This is one of the most misunderstood issues in cancer survivorship, and I see so many patients struggle with that. The traditional answer has always been absolutely no HRT, but the evidence has started to shift. Okay. First, women with hormone receptor negative breast cancer, meaning the cancer didn't feed on hormones, adding HRT probably won't increase recurrence risk. But if your cancer wasn't hormone driven, giving more hormones probably won't wake it up.
So
For hormone receptor positive breast cancer, the most common type, the data is a bit more complicated. A 2022 study in JAMA showed that carefully selected breast cancer survivors on HRT did not have increased recurrence rate. But here's the caveat. Those women were completely informed about their risks. Consent conversations were extensively had, and they were on the lowest possible dose of estrogen and progesterone. They used transdermal delivery system and had very close follow-up with their oncologist and cardiologist. The issue is, and this is why I am so passionate about this, is breast cancer survivors, particularly young women thrown into menopause by chemotherapy, face severe hot flashes, severe bone loss, and their heart risk increases dramatically. They have significant cognitive problems and have significant depression as well. So giving them HRT might improve their quality of life, but it's a very meaningful, informed conversation you have to have. You can't be like, sorry, deal with all of this. You just have to live with this. It's not the way to deal with this. You cannot just force them into fear. You have to be very careful about this.
then let's talk about the flip side briefly. What does HRT actually do to your heart?
Okay. This is where the Women's Health Initiative study actually misled us for nearly 2 decades. The Women's Health Initiative looked at mostly elder women. Their average age was 63, who started HRT long after menopause. That is more than 10 years after menopause. In that population, HRT did not help prevent heart disease. But it doesn't mean it doesn't work. It's a timing question. Then comes the critical window hypothesis. That is, if you start HRT within 5 to 10 years of menopause, when your arteries are still relatively flexible, HRT can actually prevent coronary plaque from forming. The pathophysiology is that estrogen keeps the blood vessels flexible and responsive. It maintains the healthy cholesterol ratio and reduces inflammation. But if you wait till your late 60s and your 70s, your artery is already stiff, your body is already inflamed, and your blood vessels are probably clogged. And adding hormones to a compromised system doesn't make the plaques disappear. You need to prevent it early. So this is more of a prevention thing than a treatment thing.
So then the timing of when you start matters just as much as whether you start, right?
Absolutely. This is probably the most important thing. I want women who are listening to this, or men who have wives or sisters or mothers in this age, to understand this. If you are in your late 40s, early 50s and struggling with severe hot flashes, night sweats, which are disrupting your sleep, messing up your mood, you're messing up your metabolism, HRT can be genuinely protective, and the cardiovascular benefits outweighs the breast cancer risk. But if you are 68, your hot flashes are gone, and now you're thinking about HRT because Oprah is talking about it and because everybody else is talking about it, the risk benefit ratio for you, late 60-year-old woman, is completely different. Your breast cancer risk is there. The heart protection is less likely at that stage. For the breast cancer survivors, specifically, this is crucial. These women are young, average age 50 to 50. Their heart disease risk is very elevated because of the chemotherapy you received, and their quality of life is terrible because of the menopausal symptoms. In that population, the case of HRT done carefully and thoughtfully is actually quite strong. So, there is a window, maybe early 50s, late 40s, or in early menopause. In that window, HRT shows heart benefits, and that benefit beats breast cancer risk. Once you passed in your 65s, the math changes. Medicine isn't one size fits all.
Then for women with existing heart disease or high risk,
I'm going to get really animated here, right? Women with high risk of coronary artery disease or with coronary artery disease, some of my most dramatic improvement come from strategic, carefully dosed HRT. I have seen women who have multiple angina episodes per week. I start them on transdermal estradiol and their symptoms dramatically improve. They have their exercise tolerance come back, their quality life transforms. But is this for everyone? Absolutely no. This also needs to be individualized. But it's a tool we have, and we have been too afraid to use it because of the 2002 study, which was conducted to a population where it doesn't even apply.
okay, so let's say for someone listening right now who's thinking, I might be interested in HRT, what should they be thinking about and what questions should they be asking their doctor?
Okay, here is my personalized framework. Ask yourself these questions. How old am I? And how long ago did menopause start? If you're within the 5 to 10 years of menopause onset, you're in the sweet spot for HRT benefit. If you are 15 plus years, the risk benefit calculus shifts. Okay. Number two, do I have significant symptoms? Hot flashes, night sweats, mood swing, brain fog, sleep problems, real symptoms that are affecting your life that tip the scale towards trying HRT. Okay. If you're absolutely asymptomatic, but you're just hearing this noise about HRT, that's not the reason to treat. Number three, do I have heart disease or high risk for heart disease, like high blood pressure, high cholesterol, family history of premature heart disease, prior cancer treatment with chemo? That makes HRT more potentially beneficial, not less. Then the fourth question, What's your breast cancer history? Do you have family members with breast cancer? What is your personal breast cancer history? If you've had breast cancer, was it hormone receptor negative? HRT is okay. Is it hormone receptor positive? Then you need a careful conversation with your cardiologist. But there still might be an option. Number five, strong family history of breast cancer, multiple relatives with breast cancer. That increases your baseline breast cancer risk. HRT is definitely more riskier for you, but there is no absolute contraindication. You need to discuss with this. So if the answer to these questions, there are 1 to 3 yeses, then 4 and 5 are no, you're probably a good HRT candidate. But if 4 and 5 are yeses, then you need a more nuanced conversation. Even then, wherever you are, you usually start at the lowest effective dose. Use transdermal patch cream or gels instead of oral medication. Use microionized progesterone if you need the progestin. Aim for 5 years max. You can occasionally go longer, but that is a decision to be made after 5 years. Reassess every year whether you need it and maintain aggressive screening, annual mammograms, know your breast density type. This is not you get your pills and you forget about the person who prescribed the medication. You are going to have every 6 weeks, every 12 weeks discussion with the provider who gave you these medications. So again, HRT isn't yes or no. It's maybe, and here's exactly how we do it safely. Low dose, patch not pill, microionized progesterone, limited duration, constant reassessment. That's evidence-based, personalized medicine for you.
And then for women who don't really want to consider HRT or can't, what's actually evidence based that works?
Several things, and I honestly wish women knew about these things much more. First, there's SSRIs and SNRIs. These are antidepressants. There is venlafaxine, there is FXR or sertraline. They reduce hot flashes by about 50 to 60%. Not as effective as HRT, but they do work, and they also have the bonus of helping mood and anxiety. Many women with breast cancer do take these. Then you have gabapentin and pregabalin, originally developed for nerve pain, but they are surprisingly very effective for hot flashes. Dose is usually 900 milligrams a day, but women combine it with an SSRI. Third, lifestyle interventions that actually move the needle. And that should be a part of your lifestyle, irrespective of whether you're on HRT or not. That is exercise, strength training, which helps bone health, plant-based foods rich in phytoestrogens like soy and flax, stress reduction, mindfulness, sleep optimization, maintaining a healthy weight, using a GLP-1 if need be. But here's the truth. These help. They don't match the symptom relief of HRT, but if you have severe hot flashes, waking up 7 to 8 times a night, telling a woman just exercise more and eat more tofu, that's not compassionate medicine. That is just like, just live with it and suck it up. And I don't believe in that.
Absolutely. And then it sounds like so it's not really just one or the other, it's definitely a combination.
Exactly. The best outcome, it's exercise, good nutrition, targeted supplementation like vitamin D and omega-3 fatty acids, and low dose of HRT. That's the personalized medicine, and it's always a combination approach, and it's not one size fits all.
Absolutely. And I have a good question. So, and before we wrap this episode up, I really want to ask you the question I think that every woman listening probably has and is asking. If I had to boil all of this down into one thing, one insight, what is it?
Okay, let's start with menopause is not a disease. It is a transition that puts your heart and bones at risk. HRT is one tool that we have to manage this transition. It's not a perfect tool, okay? It carries small but real risks. The question is never HRT or nothing. It's what's the best combination of strategy which is suitable for my profile, my symptoms, and my life situation. The answer is different for every woman. A 52-year-old with severe heart flashes and a family history of heart disease, great candidate. A 72-year-old with no symptoms does not need HRT at all. A breast cancer survivor, we need to think it through carefully, but it's not automatically off the table. And for everyone, work with a doctor who understands the real science and not just the fear, someone who's willing to have a real conversation with you about your risks and your needs.
And I think that, like, I really like what you said about menopause as a transition, not a disease. And I think that that's a powerful message for all of our listeners. And I think that this conversation has also been a breath of fresh air almost. And thank you for bringing actual science to a topic that's been drowning in marketing and fear. And women have so much more clarity on this topic now, for sure. And for listeners who do want to learn more or work with you specifically, where should they find you?
So I'm on LinkedIn, I'm on Instagram, I'm on YouTube, but I'm also practicing in Chennai, India, in both Apollo and Kaveri hospitals. But, if you want to reach out to me, message me through LinkedIn, DM me through my Instagram, Doc Arasi Maran, and I'm happy to answer. And if you're living in India and you want a more personalized conversation, come and meet me.
Absolutely. Thank you so much, Dr. Moran. And for our listeners, if you want to hear more conversations like this about bringing actual evidence to health topics that matter, make sure you head to infinitehealthpodcast.com. And thank you so much, Dr. Moran. I think that I personally, even myself, feel a little bit more at ease about this. And I'm sure our listeners do too. And I'm sure for all of the listeners who do have questions, we'll be reaching out to you at what you said. And we'll make sure that that's also included in the notes, and make sure that you are listening, following, and subscribing to the show. And it's a pleasure talking with you as always. And I can't wait for our next conversation.
Thank you so much, Leila.